Hello, everyone. My name is Emily Kosick, and I'm a Knowledge Manager for the Canadian Institute for Public Safety Research and Treatment. I want to welcome you all to today's session, Implementing Workplace Mental Health Interventions in Public Safety Organizations. Before we get started today, there are just a few housekeeping items that I want to go through. First of all attendees are in listen-only mode. This is to limit feedback during the presentation. Today's session is being recorded. You'll be sent a copy tomorrow, so if you miss anything, you can watch it again. Just for your information, the GoToLaunch webinar window can be blocked by some federal organizations. So if you're having trouble hearing or seeing, you may have to join us by phone. Lastly, we will be looking for audience questions at the end of the session. So please send us your questions through the questions box or be ready to raise your hand at the end of the session to ask your questions. Now, I'm very pleased to introduce our speaker for today. Dr. Megan Edgelow is an assistant professor at Queen's University. And I'm going to go ahead and switch over to presenter mode for you, Dr. Edgelow, and we can get started.
Thank you so much, Emily. It's my pleasure to be here today. And let me just get those slides in the right format for the audience.
Perfect.
Okay. So as Emily said, I'm an assistant professor at Queen's University, and I do a lot of different work in my daily life. I am an occupational therapist by training, and then I'm also a researcher in the Faculty of Health Sciences at Queen's. And I do a variety of things there, including teaching occupational therapy students, teaching in a health leadership program, and I do research that over time has really pivoted to be about work and workplace mental health. And the research that I'm going to present to you is the results of a review that I did with some colleagues at Queen's and some students as well, looking at implementing workplace mental health interventions in public safety contexts. So my co-authors on this review are Emma Schofield, Matthew McPherson, Sonam Mehta, and Aquila Ortlieb. We worked on this project over the last approximately year, and it also received some support from the Queen's University Faculty Association Fund. So what are you going to get out of this lunch hour presentation? So attendees should, at the conclusion, understand the current focus of workplace mental health interventions in public safety settings and the implementation strategies used in these workplaces. That's really the key piece. How are these things being implemented? This knowledge should be useful to employers, to unions and union members, public safety personnel themselves, leaders, managers, supervisors, in designing and implementing workplace mental health interventions. So, how did this review come about? I think it's probably not news to the audience that operational stress injuries, or OSIs, like post-traumatic stress disorder, or PTSD, are an ongoing challenge for public safety organizations. And people are reporting upward trends in OSI diagnoses, upward trends in time off work, and all of the increased staffing costs that go along with those issues. We also know that these issues create challenges for public safety personnel, their families, and the communities they live in and work in. But what we don't know very well, or what we see, is that although there might be evidence around mental health best practices, which is growing and developing, we don't always see fluid implementation of interventions. We see fragmentation a lot of the time. And we also hear from public safety personnel and their employers that things are not always meeting employee needs, or people are not sure that they're implementing things in the best way possible. So that's sort of the backdrop to this review. And the first thing before you do a literature review is you always have to look to what's already out there. So when I started looking around in the environment to see, has someone already answered this question? I found a variety of things. So there are definitely a growing number of workplace mental health best practice reviews. Some of the more notable ones I've listed here. So we've got a review around interventions for work-related PTSD. That paper found about 19 different interventions, but it didn't necessarily comment on how the interventions were being rolled out. Then we've got from Cullen and colleagues in 2018, looking at the effectiveness of workplace interventions for a variety of health conditions. So that, again, strong evidence, but not necessarily focused on implementation. And then a review of my own related to occupational therapy, looking at return to work interventions, but finding that those interventions are really individually focused and not necessarily globally related to workplace mental health itself, or how they could be implemented on a grand scale. So then the next thing you do is turn your attention to what do we know about mental health best practice implementation. And again, there are several reviews out there that tell us about how to implement things in an empirically sound way. A lot of them are more focused or targeted towards health providers and health facilities. And at the end of the day, before the team embarked on our current review, we were pretty confident that no review of workplace mental health implementation in the public safety sector existed. So before we started the review, we kind of refined what question were we asking, or maybe series of questions. And really there's three things that we wanted to find out as we went to the literature. So we wanted to know what mental health interventions exist and are being used. So sort of what is being done, what are the characteristics of those interventions, and then ultimately what strategies are being used in their implementation. So that was really the key piece. How are these interventions being implemented at the level of the workplace? So that led us to sort of further refine what were we looking for when we went to the literature and searching. So our population of concern, really public safety personnel or employees, and then all of the keywords that might go along with that, such as firefighters, first responders, communications officer, etc. And then we had two concepts. We're putting together the concepts of implementation strategies, which also might be known as dissemination or diffusion or training or all those other keywords, along with workplace mental health, which might be considered best practices, treatment, coping, health promotion, all those different concepts. And then ultimately, our context is public safety organizations, or could be employers, managers, different levels of sort of organizations there. So that's overall what we were looking for in our inclusion exclusion criteria. The articles that we found really needed to be zeroing in not only on public safety personnel, but on the context that they work in. So that's how we narrowed the criteria of what we were looking for. And then our methodology for the scoping review, we used the Joanna Briggs Institute methodology, or also known as JBI, and followed a pretty standard protocol for a literature review of this kind. And we searched databases that included Medline, Embase, PsycInfo, CINAHL, and Web of Science. And what we also did is, once we found relevant articles, we mined those reference lists to see were there other articles that might be useful. And we also looked to see had they been cited by other relevant papers. So once we found our relevant pieces, we looked around in the environment to make sure that we had found all other connected articles. And then we deduplicated and did data extraction. So you think about the scope of this literature, how many articles did we ultimately find? We found masses of them. So we found over 60,000 records to sort through. And then eventually with hand searching, we included another 74. Luckily, almost 20,000 of those were duplicates, but we still needed to screen more than 40,000 papers, which makes a team really important, and team approach, because every record gets read by two people. So lots of screening, reading, getting the sense of what's available. And we ended up at the end of the day going from more than 60,000 results down to, thankfully, 89 papers that were going to help us answer our research questions. So when we looked at what, who is doing this type of research, what are the contexts that are being studied, we found that I'll say we put no date limit on the review. So we went as far back as anything that would be available, and the furthest back we found was 1979. And then the most current was 2020, because that's the year we did the review in. But 70% of the papers were coming from the last decade. So you see a real pickup in the attention to this research space within the last 10 years. Again, I doubt that's a surprise to anyone in the audience, because a lot of the infrastructure that has been built around public safety research has really come about in the last decade. I also was not surprised by the demographics of where the research was coming from. So overwhelmingly, we found that it was coming from sort of westernized countries, North America being the leading continent, with the United States having the most articles found of any country, 8 from a Canadian context. And then we are seeing papers from Australia and New Zealand, also from countries in Europe, and then not very many coming from countries in Asia, or Africa. So not a lot of studies that would represent a non-Westernized context. So what we found is that the majority of ways that these interventions were being studied were quasi-experimental and had some kind of control and treatment group. So typically the papers were including that, there's some kind of intervention. Either there's a control and treatment group where, one group does the intervention, one group does nothing. Sometimes people were acting as their own controls, where their results kind of pre-intervention and post-intervention would be compared. We did see so about half were coming from more the quasi-experimental lens. We did have quite a few that were more traditional randomized controlled trials, where you have the very separate control and treatment groups. And then many fewer papers looking at other ways of understanding intervention. So very few mixed methods, qualitative, cohort, etc. So not a lot going on beyond that sort of quasi-experimental or experimental design. So who was being studied? We found that overwhelmingly the research was done in policing contexts, followed by firefighters. So about 2/3 of papers were speaking to police context, and then somewhere around a quarter were related to firefighters. And then you can see that other populations were much smaller. So paramedics or EMTs were only 6 of the papers, applied to corrections was only 4, first responders in sort of a generic category was 2, emergency dispatch 2, probation 1, and disaster workers 1. So really overwhelmingly that focus on police followed by fire. What we also found is that 79 of 89 papers were focused on frontline workers. So again, overwhelmingly, these are interventions being delivered to the front line. So what was actually happening? A very, very strong focus at the workplace level on stress and resilience. So half of the papers were targeting stress or stress management. Then we had a quarter looking at resilience. So, we've got 71 of 89 papers that are really strongly in this kind of category. And I think part of what we see today is sort of an increasing focus on resilience. Some of the papers that were coming from stress management, I would say, were from beyond that 10-year window. So you do see sort of a trend where approaches that might have been called stress management in the past are actually trending towards now being more of a resilience focus. But again, overwhelming focus on stress and resilience. 18 studies were focusing more kind of on symptoms or symptom management, and then 14 of them were more wellness focused, which might have included physical activity interventions, and 5 focused on suicide risk and prevention. And you'll see there that the studies overall are adding up to a few more than 89 there, and that's because some interventions were targeting more than one thing at the same time. So I would imagine that this is not surprising to anyone in this space because there is a high availability of stress management and resilience interventions in public safety, and there's also a lot of research going on in that very targeted space. So it was not necessarily surprising to find that. The implementation, to me, it was a bit of a surprise, but people who work in this area might not find it surprising at all. So 66 of the 89 papers looked at some form of group training. And then beyond that group training, we saw 6 programs that were individual training and 6 programs that were online training. So very big focus on training as the actual delivery method or the implementation method for the workplace mental health strategy. What we also saw was that there were 10 studies implementing some kind of debriefing program, 6 of them in a group or 4 of them more individualized. And less common were individual activities, 5 of the papers, and very rare in the sample out of 89, only 2 more global quality improvement programs that would have looked at interventions sort of across a spectrum of employee needs, as well as measuring longer term results. Interestingly, because I know sometimes there's a debate about, how long sessions are and, is multiple better than single, we found that most of the time, actually, the group training was actually multiple sessions. So it was less common to see a single session program. 27% of papers that included a training component were single sessions. So about 3/4 of the training actually were happening in multiple sessions. But I think an important thing to point out here is that the majority of programs were targeted at the employee level. And only 5 of the papers we found were actually about either A, the mental health of leadership, or B, something that was enabling supervisors or managers to focus on employee mental health. So there were only 5 papers in the sample that were looking sort of beyond the front line. And these were only found in police or fire contexts. So when we think about, what does this mean for how can we use this information? So really the review findings are most applicable to Western nations because that's where the information was coming from overwhelmingly. Again, thinking about, what populations are we seeing pop up? 2/3 of papers were really about police, and then about 1/4 were about fire. So, there's sort of a gap there for other PSP categories, particularly paramedics, corrections, communications, and other groups were really limited. So not a lot of focus there in the sample. Other things to think about, what were we seeing with the implementation, which was the big question, like how do these, once we have this intervention that we agree is worth doing or that we see that people have interest in, like resilience or stress management, how do we actually roll it out for people? So big emphasis on group training programs. Some of the caveats there is that when we think about group training as sort of the go-to method of delivery, the reality is that we might not be engaging all of our participants fully. And people may be attending voluntarily or involuntarily, so you may get more or less actual participation once people are in the room. And another sort of thing to think critically about with implementation that is focused directly on the frontline worker, it often locates the mental health problem within the employee. and might minimize the external contribution of the workplace. So it makes it so that the employees just need to manage their stress better or just need to be more resilient, which might only capture part of what is really happening for people related to workplace mental health. The other things to think about is that when we look more to the broad implementation literature, there's a lot of different ways that things can be rolled out, but we really weren't seeing that in the sample. So implementation strategies might include educational workshops, but sometimes also they are more broad informational campaigns. They could be more personalized and targeted training and feedback. There could be providing instructional and resource materials, so maybe they're self-study or asynchronous. People might also benefit from supervision and monitoring to actually ensure that whatever skill they were meant to be learning, that they're actually able to do that. We might also see use of peers and opinion leaders to push information forward, or the use of things like cases and video examples for instructional design. So, you know, lots of strategies available and also backed up by implementation science evidence around their use, but not necessarily seeing it in the literature that we found, or seeing it in use, I should say. So what else to think about? So when we think about broadly, what do we know about the evidence base? One of the things to think about in a scoping review is that we were looking to map the breadth of the research and get a sense of what is happening in the space. But the goal of a scoping review is not necessarily to evaluate the evidence of each study that's included. So when we think about, you know, how do we discuss the results, it can be useful to look broadly to the evidence base in the public safety space. So what we found in the review is that only 2 of 89 papers were actually looking at comprehensive quality improvement. So very few looking across, you know, sort of the bigger picture in an organization, as well as all trickling all the way down to the employee level, doing it over enough time where you might be actually able to measure workplace mental health outcomes, you know, over years. So, and I think, to be fair, things like that need a lot of funding to run. And often it's easier to get some funding to roll out something that is more training based. When we think also to what do we see in some of the systematic reviews that are coming out more broadly about public safety, some of the more promising practices are showing up as exercise and also stress management with imagery components. We didn't find really any imagery components being used in our sample, and also not a large focus on exercise interventions, which are pretty well, you know, doesn't seem to matter what population you study an exercise intervention in. Could be the general public, could be, you know, workplaces writ large, could also be public safety. The evidence keeps coming back that exercise has a strong link to well-being and overall mental health. And often these interventions are, you know, more easy to implement because there might already be existing public health resources or health promotion resources within an employer. So I would say I was a bit disappointed in the sample to see that exercise was showing up in, I think, only maybe 10 of the papers. So even though we know that some of these things do have some evidence behind them, we're not necessarily seeing them in practice. And I would also say to continue to bang my exercise drum, it's not new news that exercise is really highly, keenly linked to our overall mental health. Also, what we see is that overall, and there's been several systematic reviews that have really made this point to date, is that debriefing programs, particularly ones that are not optional and that are group-based, tend to not be beneficial. But despite this, we did see six articles in this review, which again makes sense. We are looking at a bit of a historical sample, so it could be that employers now are moving away from things that are don't have a lot of choice to them and may unintentionally sort of amplify trauma exposure. It could be that employers are moving away from those practices, but because our sample spanned a 40-year window, maybe we were still finding those papers. Other things to think about from an evidence base when we think about what are we going to implement and why. I really find this review by Joyce and colleagues from 2016, which looked more broadly at common mental disorders, which would include things like depression and anxiety disorder. When they looked at this broadly in the world of workplace mental health, one of the things that they sort of put forward in their findings was a bit of a framework or something that would help us think across a spectrum of prevention. And so I love to sort of bring forward anyone who knows me knows that I love to speak about prevention. And also that we have to use a critical lens on prevention, because with public safety work, it might not be possible to avoid exposure to traumatic incidents. So when we think about prevention, it's not really about preventing the incident, it's more about often promoting mental wellness. And so the first level that we would do this at would be called primary prevention, or as I might refer to it, promoting mental wellness. And interventions that have sort of a lot of bang for their buck in this category include things like increasing employee control. And so sometimes this could be around self-scheduling of shifts, work from home scenarios. These will have sort of, caveats for public safety environments where there may not be as much control that can be given. But I think sometimes employers can get creative about where can employees indicate choice in their workplace. Again, physical activity keeps coming up, as well as workplace health promotion. So these are things that we might think about implementing in workplaces. And as I said, we didn't see these categories borne out as much in the sample, but we did see a little bit more of is things that would be thought of as secondary prevention. And so secondary prevention is about when you have definitely been exposed, that we want to either prevent the development of mental illness or mitigate the severity of that resulting mental illness. And so things that can help with that are types of workplace screening that are not punitive, but actually lead to quick access to tailored treatments. Stress management programs do have some good evidence behind them. But again, sort of echoed here that caution against routine psychological trauma debriefing, and more of a focus on psychological first aid and individualized supports. So the one thing that we really saw in the review coming through was that focus on stress management programs, but we saw not a lot of implementation of workplace screening and some implementation of that group trauma debriefing. So again, when we look to the sample of what's going on in this space, it's matching to some degree what the evidence would tell us, but there are some things missing, like that workplace screening. And then there are things happening like the routine group trauma debriefing that would at this point be recommended against because of the evidence. Other things that we might do across this spectrum would be tertiary prevention, which is about preventing work-related disability. So at this level, the person does have an active mental health condition, but the hope is to prevent ultimately work loss. And so for some of these, we know that the evidence would speak to work-focused psychotherapy, gradual re-exposure to the workplace, and often which becomes a natural partnership for occupational therapy and psychology. Now, in our review, because we were looking at things that were more high level and more focused at the level of the workplace, we did not look into tertiary prevention or things that are have a more individualized focus. So that wasn't necessarily the focus of my review, but when we think of across a spectrum of things that could be implemented, we would need to have sort of that tertiary category available and sometimes supported by something like WSIB or WCB, depending on where you are joining us from Canada, or maybe WorkSafe BC, whatever your workplace insurance board is called in the province or territory that you're joining us from. These things would need to be available, and evidence would also say they need to be available rapidly for people who maybe don't get their needs met fully by those higher level workplace interventions. So thinking about sort of the scope of the review, some of the limitations that we have is that it's a scoping review and not a systematic review. So it's really looking at the breadth of the literature versus necessarily the quality of each intervention found. But it's possible as well that we could have missed some articles out there depending on search terms and sort of, you know, the time that is searching as well. So those are always some of the limitations of a scoping review. So to sum up and bring us closer to our discussion portion of the presentation, so what did we find? Overall, public safety organizations are frequently reporting on results from stress management and resilience interventions. And the most common people these have been tested on are police and firefighters, and also most commonly happening through multi-session group training. I would suggest, as well as my research team, that a focus across a range of PSP careers, including paramedics, corrections officers, emergency dispatchers, and other categories that may be missed, and using implementation strategies beyond group training. Not that you can't use group training, but I think maybe it can't be our only strategy that we use for implementation. What we also find is that this research is currently expanding. You know, many of the studies found were published in the last decade, and there are plenty of ongoing evaluation activities out there. And I would say if this review was done in another 10 years, we might, you know, find ourselves looking at another, you know, 100 or some articles as well. So when you're thinking about, you know, for any employers or union leaders or managers, people in sort of supervisory positions, when you're thinking about, you know, what to take away from our discussion today, that really should be considering a variety of implementation methods. It can include group training, but also potentially thinking beyond group training. There could be synchronous content, you know, asynchronous takeaway content or self-study content, materials that people take away with them, thinking about multiple contacts and follow-up times, potentially mentoring as well, and supervision to see if people have actually learned what we hoped that they had learned. We also need to consider the layers of people working in organizations. So we really found that the overwhelming focus is on frontline workers when it comes to these interventions and their implementation. And so I think there needs to be more done for leaders and supervisors, and also more, when we think about mentoring or supervision, more interventions that actually look at the rollout of things, you know, from higher up to the front line. And really those groups are likely to have diverse needs related to mental health, and potentially diverse ways that they would want to have interventions be implemented. We also need to think critically about where interventions are focused. So the overwhelming focus of the interventions found were on resilience and stress management. Now, these are worthy interventions, and there are programs out there that do have good evidence. The thing to think about is that they situate the issue with the employee and not within the work environment itself. So it's a very kind of singular focus that continues to expect the employee to just manage their stress better or just be more resilient. And so I think we have to think critically about how fruitful that kind of singular focus is in the work environments that people occupy. And then I would also have people think about how do we actually layer our approaches across those prevention levels that I mentioned? So as an employer, do you have programs that are more generally about employee wellness? Are there opportunities for more flexible work? Are there opportunities to incentivize or make available opportunities for physical fitness? Are there other health promotion strategies that can be used? And a lot of these health promotion strategies, are already out there in the health promotion world or in the public health world. And also some public safety groups do have things that have become more tailored in this area. I'm aware of a program from the IAFF for firefighters around a physical fitness program. So I know that in the association environment and the union environment, often there actually are tailored interventions already out there that are focusing on sort of that physical wellness and how it could also enable more mental wellness. Then when we think about, beyond the health promotion focused to actually screening people early for symptoms and streaming them towards support, moving more towards mental first aid versus non-optional group debriefing scenarios, and overall ensuring that there is early access to those individualized supports. And then at the final layer, final level, people might find that work-focused psychotherapy through psychology or occupational therapy, and often in partnership to help people maintain work and return to work could be fruitful. So those are some of the takeaways. I'll be happy to talk about them more in just a moment here. If people are wanting to kind of get into the nitty-gritty of the review of the articles, there's certainly a wealth of information there. We published the protocol for the review in JBI Evidence Synthesis earlier this year, and then later in the year, the article itself came out in the International Archives of Occupational and Environmental Health. And if you're someone who doesn't have easy access to a journal subscription through an institutional library, I would be very happy to email you the review if you get in touch. So please don't hesitate to reach out, and I will share my contact information shortly here. Other things I wanted to do before we get into the chat is just to acknowledge Queen's collaboration with JBI and some of the mentorship I had access to complete this review, as well as some others at Queen's University who were really instrumental to kind of early conceptualization of the review. And there are some references again, which I'm happy to share with people if you want more information kind of behind the scenes after. And here's how you can contact me if you do want to reach out to get more particulars about the review or any of the resources that I've cited today. And now I would be very happy to move into more discussion.
Perfect. Thank you so much, Dr. Edgelow, for that great presentation. Just want to let the audience know that SIPCERT actually will be doing a summary of review. It probably won't be posted till early in the new year, but we'll make that available. So there's a lay summary type version available for people as well. So, and post your wonderful talk with it. So we do have some questions that have come in. The first one is from a doctor who's actually currently working with rural fire departments. And he sees often fear rises up to block mental health efforts, and use of provincial CISM programs is done, but ongoing mental health programs are kind of nil. So how would you think that people should get started with doing different interventions?
Mm-hmm. I think that some kind of health promotion approach sometimes is low-hanging fruit around incentivizing exercise. Often it depends on the scale of the employer. It sounds like in the question asker, it's a more rural setting. I have seen fire departments sometimes put in something, like a gym or a way to access some fitness equipment on downtime. I've also seen larger scale employers, discount a gym pass or have some sort of competition, you know, how many hours can be logged at the gym or things like that. So sometimes I think those broader scale health promotion approaches, they can also break down stigma a little bit as well, because although you're targeting mental health, you're sort of doing it through something that is already part of the, you know, a fitness of, or a culture of fitness. So I would say that could be a potential approach that I have seen some employers bear some fruit with. And I would also say that sometimes when you know, essentially nothing is happening and it's a blank slate, it might be an opportunity to hear from the employees themselves. You know, what are they actually looking for? Sometimes people are looking for more structured intervention around something like coping and resilience. But sometimes people, you know, have been to too many of those trainings or haven't found them very tailored. So I think sometimes turning it around to the group or engaging union members to find out from membership what would people like to see more of might be fruitful as well.
So we do have a question. So for your categorizing of the interventions, how are those categories defined and rated?
So with a scoping review, we're not doing rating. So we are categorizing, but we are not rating the quality of intervention. So that would be in a systematic review, not a scoping review. But the way that we looked across the categories of the interventions is we looked at, you know, who were they focused at, what kind of population, how long was the duration, was it multiple sessions or single session, what was the content, and what sort of evaluation was done of that content. So those are some of the things that we looked at that have a lot more detail in the review article itself that I can share if you want to know more, if you reach out via email.
So you noted that there were 23 studies that were involving firefighters. Do you have any idea how many firefighters were actually included in that total with the articles?
Yeah, so across the 23 articles, it would represent actually hundreds to potentially thousands of firefighters. So a lot of the samples that we saw for group training were actually quite large. And a lot of the firefighter papers that we found were coming from North American context. So there was, I would say, a fair amount of firefighters represented in that sample of 23 papers. And again, if you get in touch, I can share the paper that contains tables and tables and tables that will give you kind of more information on exactly what was happening for different employee categories.
Okay. So next, with respect to the debriefing model, you noted group debriefing is not indicated as helpful. However, would using the steps of critical incident debriefing or the diffusing model, or would individual staff members be helpful? So is the problem with the framework or with the group format?
That I think is a hard one to tease apart, and not having done research myself on the debriefing models, I don't know that I could comment for sure on what the issue is. I know it's been theorized that part of the difficulty is more the group setting, and that people may be coming away with one experience, but then when they sit in a room with 20 other people, they end up sort of dosed with everybody else's experience, or someone who didn't initially find the incident that traumatic maybe finds it traumatic after hearing and maybe not being able to make a choice about whether or not they are there. But not being sort of an expert myself in debriefing, I would hesitate to say definitively that, you know, the model itself is issue free. What really I think has been found when they've looked broadly at the critical incident debriefing research is that often people are A, potentially not harmed, but B, potentially not helped over time either. And so that's another kind of critical thing to think about. I know that some colleagues that are involved with CIPCERT did do a review that came out in 2021. And Emily, you can comment if it's summarized on the CIPCERT website, I think it was Greg Anderson was maybe the lead on that, looking at more critically at peer interventions and critical incident intervention. So I think there is a more up-to-date review on that topic in particular out.
Yeah, and I actually do believe that we do have that one summarized on our website currently. So yeah, it is available. If people want to take a look, there's a lay summary available for that, or a research summary available for that. Next question is, were there any hospitalizations of PSP in the articles that you studied?
Not that stands out from having looked at the papers on a broad level. And a lot of the time, because what was being targeted in those interventions was really the higher level, sometimes slightly impersonal stuff through the group training, we wouldn't necessarily have sort of seen that need be triggered. And I think reviews that are more about the individualized interventions like psychotherapy might contain more information related to that. But because our papers were looking at more high-level stuff, the kind of things that are mandated for people to participate in the workplace, that didn't stand out to me as an outcome from those papers.
Did you find in the papers that there was any talk about the experience of the people receiving the intervention? Like, any opinions of how they felt the intervention was successful or not successful?
Mm-hmm. Yeah, so there was a lot. I would say that most of the studies included some sort of feedback from participants. And feedback tended to be, I would say, globally, typically positive. People might have given particular points around, training content, how to improve it, things like that. I think in general, what we find is that people are happy to see these issues being addressed. But we also need to be cautious that, for every employee, if group training is really, the biggest focus, is that meeting the needs of every employee? And also, are we missing the opportunity for some of those more health promotion, higher level strategies, just to have a more well workforce? And also, are we locating the issue too often within the employee and missing a chance for a critical look at the employment environment as well?
Did you come across any examples of successful interventions that target oppositional workplace culture? So cultures of just be resilient, competition, toxic masculinity. The question is coming from someone who works in U.S. federal crisis response.
Right. I would say that those are all very important elements. They were not things that we were extracting when we were looking for the data. So it could be that they are in some of the papers, or you might find them coming up more often depending on the employer environment. So maybe you might see it popping up more in a correctional environment or more in a policing environment, but it wasn't a category that we were extracting data specifically around.
Do you plan to study the impact of workplace mental health on employees, so particularly around the performance review process?
I think that is an interesting element. I have a little bit of seed money at the moment that came through from SSHRC, so the Social Sciences Research Council here in Canada, to set up sort of the next thing I'm launching into in the new year, trying to look at organizational factors, which could include employee reviews, could also include any number of things put in place by an employer or any number of contextual variables about an employment setting. And the plan is to potentially design a tool or some sort of checklist around what could be going on organizationally, and then to engage public safety employers to use the tool, take the checklist, and then report back on what kind of workplace mental health outcomes are they having? What level of sick leave do they have over the last 5 years? How many suicides have they had? How many people are on long-term disability right now? Or conversely, there could be some positive mental health outcomes that we look at. So that is definitely on the radar. And I will say, when we look to include workplace variables, I think that things around supervision and feedback will be included as sort of an organizational factor. So stay tuned for that. If you're in a Canadian context, I will eventually be looking for public safety employers to be part of a pilot group to actually help me refine the tool and sort of put it to use. So if that sounds of interest to anybody in the audience, please feel free to reach out and I can sort of take your information for future pilot testing.
Okay. So regarding primary prevention interventions, other than fitness, can you expand on specific examples and promising practices that would fall under the workplace health promotion?
Yeah, so a lot of the health promotion, it goes to things that you might actually think of that your health unit might have been doing, before their entire focus across the country became the pandemic. So these are sometimes things like smoking cessation, healthy eating. Sometimes they even get to the point of, parenting or family dynamics, or, sort of healthy community type interventions or healthy family interventions. So all of the things where if you opened your public health unit's webpage and navigate past all of the current COVID information, that you might find a variety of existing programs, and really often there are things that are more typically focused on healthy body, like the smoking cessation or diet and exercise, but ultimately have good evidence that they link to mental health as well.
So first, just a comment that it's been a wonderful presentation, and then a question saying, any thoughts on what's causing the discrepancy between programs that have a reasonable evidence base and programs you are seeing in your review that are being implemented in a PSP context? So if interventions A, B, and C work, but PSP contexts are using A, D, and E, where D and E are actually not super great, why is that happening? What's happening?
Yeah, I always think of the sort of the concept of inertia, the object at rest and then the object in motion. And I think what we see, and this is not just that public safety is guilty of this, I would say institutions are guilty of this. We had a problem, we built a solution, the solution continues to roll out. Maybe we don't even measure anymore how well the solution is working. It's just happening, and we picked A, D, and E, and these are now what we have. And it takes a lot for an organization to sort of put the brakes on, regardless of context, and decide to go in a different direction. And one thing we see as well is that sometimes things that have early promise, like critical incident stress debriefing, there were some good studies on it when it first came out, and there was not a lot of interventions available, so a lot of employers implemented it. What we found over time is that once enough studies had been done, that there wasn't actually, the evidence base wasn't that great for it. But that concept of inertia, like we're already in motion, it's already happening, maybe we're not even measuring our workplace outcomes. So I think what we have to see, and again, this would not just be specific to public safety employers, but to employers generally, often we need to sort of stop and survey the environment and look at, is what we're doing actually what the evidence today would tell us we should continue to do? Are there shifts we should make, and are there actually new or different things that we should try? And that's where I would say in those, out of the 89 studies, the 2 where we saw comprehensive quality improvement, those were sort of the most promising, where they're looking broadly at the environment and they're measuring change over years versus potentially weeks or months. And all of these things are really hard to do. And again, it's no criticism of public safety employers. It's really a reality of institutions.
What kind of organizational changes are needed compared to these employee-focused interventions like resilience?
Well, I think if people attended one of the November virtual town halls was Don McCreary speaking about burnout, actually, which is a little bit different than what we're talking about today. And burnout is not necessarily a mental illness or a diagnostic category, but it is something that tells us, often when people have burnout, there is an institutional tie to burnout, and there's something going on in the environment. And I would say that Dawn's presentation was quite congruent with what I talked about today, where we continue to focus on just having the employee do better and sort of structurally ignoring what's going on in the environment, because the environment is the hard piece to change. And one of the points he made about burnout actually is that sometimes when we think about kind of like work resources, or some of the things that I've been talking about with flexible work, is that we actually need more workers. And that is a hard one, because often people are not in control of budgets. Often these are highly skilled jobs, so it's not like you can just hire somebody tomorrow into the role. But I wonder if we need to start talking about this, and I think this also needs to be spoken of in relation to healthcare professionals, that maybe we just actually need a deeper roster, a deeper team, so that when somebody needs some time off or some time to decompress, they can actually take that, and they don't neglect taking it because they worry about the rest of the team and sort of the shortage of resources. And this, I was speaking with a physician yesterday, said, to him this applies to nursing as well, where surgeries are being canceled because it's not actually the surgeons, it's that there's no nurses to be available in the OR or for aftercare, all those things. And it made me think about some conversations I've had recently with paramedic organizations, where people are just, calling in not ready to work. And it makes me wonder, do we need to start rethinking what is an acceptable worker complement? Is there some kind of reserve workforce? Again, very hard to implement, not something that could happen tomorrow, but potentially I think the conversation needs to shift to, in an area that takes a lot of human resources like this, do we need essentially, more bodies? And also, are there ways to be more flexible with work? That's another one that has good evidence sort of broadly in the spectrum of work, is work flexibility and the amount of choices that employees can make. Now you can see why it's much more easy to implement group training than to make these kind of structural changes. And so I am not faulting any employer who hasn't made the bigger picture changes, because those are ones that are often take seismic shifts in work culture, and also take a lot of reorganizing of finances. Would the hope be that maybe less would be spent on sick time over time? Yes, I think that would be the hope, but I think it's a conversation we need to start having. And I'm aware that we have only 2 minutes left, and I would also like to speak to workplace culture as well. Because if you've got a culture where people are being discriminated against, people are being bullied, there's stigma in the environment, there might be gender discrimination. We know that all of those environmental things also really impact people's mental health quite poorly. So we might need to be thinking about organizational culture as well.
Okay, so as you indicated, we are getting to the end of our time here. I think we have actually managed to do most of the questions, so I think we're in pretty good stead. Let me just see here. I did see a hand raised. Let's see if I can find them. All right, I have Scott, so I'm just going to unmute Scott. Scott's going to give our last question of the day. And go ahead, Scott. You are self-muted. Oh, there we go.
Hi, Megan. Great presentation. Thank you very much for putting this together, because I'm a firefighter in Ontario, and I see the more the evidence base and side of things from a practical perspective. And I can say that a lot of what's in your report, I'm pleased to say that in one aspect or another, we've had some success in implementing in our fire service. So it is possible. It does take deep pockets. Just the one thing that I just wanted to, and sorry, I don't mean to be a critique or anything, but over half of the paramedics in North America are actually considered firefighters, particularly down in the States. So that's probably why there's such that drastic difference. So particularly in the fire departments down in the US, they would come under that same, I guess, side or perspective as well.
Yes, yeah, Scott, and I'll just hold you there to tell you, yes, I agree. What we did do though, when we did the data extraction, is we went into every article and we looked for what are people called and what are they doing. And so sometimes you find that things might have been focused on more than one category within. So we did do a deeper dive to see who was actually in the sample. So we did to a degree control for that. So thank you. Thank you for bringing that up, because yes, there is sort of different categorization. And thank you so much for saying that, you know, it is possible. I think it's good to end on a hopeful note, because this can feel kind of daunting, but I think the first step is really looking at what is happening, trying to take honest stock of how does what is happening in an organization match what we know about some of the best practices, and maybe just inching bit by bit towards, you know, making a little bit of a change or implementing, you know, one new thing, you know, over a calendar year, sort of trying to make it more bite size.
Definitely. Well, I want to thank you so much for being here today, Dr. Edgelow. It's been a great presentation, and to everyone in the audience, it's been a great session, lots of wonderful questions. There will be a quick survey at the end of the town hall. We hope you'll take a moment to complete it. We will be hosting our next town hall on January the 13th, so into the new year. It is titled Fundamentals of Sleep, and it's with Dr. Colleen Carney, and she's going to go through a lot of commonly asked questions about sleep and give you some solutions and options to use depending on what your sleep issue is. This session is a must for anyone who wants to know more about good sleep and treatments that are effective. Website links for this session will be in your follow-up email with the recording of today's session. Thank you so much for attending this town hall. I hope everybody has a wonderful holiday season and takes care and stays safe. Thank you again for being here.